All right, welcome to today's live. I'm here with Lesley Arbour, and I am so excited and so honored to have this conversation because I know that it is going to help so many women and get Lesley's work in front of even more women to help them heal their relationship to their body and their pelvic floor. So welcome, Lesley, and just a little introduction for Lesley. She has been in practice for 36 years, specializing in women's health and pelvic muscle dysfunction. She is an expert in behavioral medicine with a focus on perineometry, a biofeedback treatment of disorders of pelvic musculature and sexual dysfunction. Lesley is also a master therapist in myofascial release, which I'm really excited to hear more about. And she combines this with her expertise to develop a unique medical treatment known as Pelvicology for the treatment of pelvic conditions. She developed a certification program in 1985 for the treatment of pelvic floor dysfunction, which is now an ongoing web-based offer. And yeah, let's dive in. Lesley, thank you so much for being here. I know with the Mercury retrograde stuff, we're having a little lag in the Zoom call. So we might have to pace it a little slower, but Lesley, thank you so much for being here. And I'd love for you to share a little bit about your own self-introduced bio and your journey, because you have such an incredible history of this work and really how you've been on the forefront of bringing this into mainstream public for women. So I'd love to hear more from you.
Well, thank you very much. And obviously, I always get a little nervous when I'm working with a computer, as it just flashed across the screen that
oh, we may have lost her.
Okay.
Oh, we lost you. Yeah, we lost you. So you might want to start over.
Okay. Yeah, I'm a nurse, registered nurse, and I've worked in the hospital. I do rehabilitation nursing, and my focus has always been on women's health. And I'm a counselor, so in my life before 1985, when I met Dr. Perry, I was counseling women and learning really just how much information and how many needs women have, because they're and not really understanding their body. And to be honest with you, I was 45 years old in 1985. So if you add that up, I'm 79 now. It was a real wake-up call for me. I personally had a intercourse pain. So we'll just take out the uterus and everything. And then I was left with bladder problems. I had a leaky bladder, and believe it or not, I had 3 bladder surgeries. The third one, and this was before I met Dr. Perry, was in 1983, where I had to wear a Foley bag and have it wrapped around my leg as I walked around, because I was so scarred up from the tissue, and I didn't even realize from the surgery that that could do a number on my vaginal floor. And so when I met John Perry, I had already studied with Masters and Johnson as sex therapy, and I was at the University of Pennsylvania doing a graduate program in sex therapy, and John Perry was lecturing. And for those who don't know John Perry, he wrote the book, The G-Spot, and I don't know if you can see it here. It's a pink book. And he co-authored it with a nurse and a psychologist, and he is a psychologist himself. And the G-Spot talked about the vaginal orgasm. And what it did is prove the theories. It was a group of lesbians in Miami that were very focused on, they had this crazy thing called squirting and G-spot or ejaculation. And anyway, I'm not going to go into the whole theory and everything, but Okay, did you hear when I talked about the perioneometer?
It just cut out. If you could show the book again too, because the video was paused for most of that as well.
Okay, okay, there's the book, The G-Spot.
Yay, yeah.
The bestseller in 82. Unfortunately, I didn't meet him in 82. I wish I had. But in 1985, I met him. And so I was very interested. I had read the G-Spot already when I met him at my course at University of Pennsylvania. So we hooked up together, and I guess that term, we just went out for coffee. So it's a big difference. But so the G-Spot, he worked with a bunch of lesbians. He had developed a perioneometer, which is like a Tampax, and it has electrodes on it, and you can insert it, you can stay dressed, insert it in the vaginal area or rectal area, whether a man or a woman, and you can see what's going on with the pelvic floor. Now, if I told you I had a problem with my arm and I went like this, you can see, and I could say, well, oh, I can't straighten out my arm. Well, you can see it. Well, he developed a computerized program, and I have here, I don't know if you can see it.
Yeah, it's
So
showing now.
The patient has the perioneometer inside, and it's hooked up to an EMG machine. And we tell her to squeeze her muscle, her PC muscle. The pubicoccygeal is what the PC muscle stands for. It goes from the pubic bone in the front to the coccyx in the back. So when you squeeze the muscle, the electrode on the sensor inside the vaginal area would make those marks on the screen. So you can see exactly what kind of a PC muscle she had. Like, this is a good PC muscle. Low resting means probably she doesn't have any pelvic pain. And then straight up, holding it for 10 seconds. So that builds up the tonic part of the muscle. So she probably has a very, very good muscle. But sometimes what happens is you get this reading where you can't really hold it up square. I don't know if it's definitive enough to see that it just holds up, down, up, down, up, down, up, down. She's really trying on that one. And then you got a numerical evaluation. And then you did an endurance test, which showed the muscle and how long you can hold it. In other words, we'd say, hold the muscle as tight as you can and let go. And we watch it fatigue, and usually 20 or 30 seconds. All right. But some people had spasms. And so this is what happened, that the muscle would go up and spike a little bit, and go down and then spike a little bit. So it was all very, very good so that people could really understand what was going on in this. I call it the hidden muscle. Mm-hmm. But the pelvic floor is very, very important because I didn't realize this at the time. But when I was teaching, we developed the Perry Institute. We had a certification course for nurses, doctors, physical therapists, and psychologists. And psychologists could do this training because the patients were dressed and all they had to do was put in the electrode. And so I was talking to my class, and I was incontinence, and I had the 3 bladder surgeries, but I couldn't get past 5 microvolts of strength. And that was very frustrating to me because I said, if I don't live with a perioneometer in me and my home trainer, to see, or hooked up to a computer, I leak. So I just presented this to the class because it was a great class. And I just said, I got to let it hang out. And physical in the group stood up and said, I need to evaluate you. And I said, fine. So she took a look at me. I was dressed in my lecture clothes and everything like that. And she said, oh my God, you have so many myofascial restrictions. She could see that my shoulders were uneven, and she could see that my pelvis was uneven and that I was tipped forward. And so she said, you have myofascial restrictions and you need to see John Barnes. I did not know what she was talking about. I had never been to a physical therapist. And here I am, 45 years old, had put myself under the knife 4 times. And here this physical therapist that I knew nothing about physical therapy told me that you need to go see John Barnes. Well, as it was, our clinic was in Bryn Mawr, Pennsylvania. John Barnes' office was in Paoli, Pennsylvania. It's on the main line and it's just about 2 towns away, 20 minutes. This expert that started Myofascial Release was 20 minutes away from me, and I didn't even know about it. So obviously, I went to see John Barnes. And if you wonder why you can do a myofascial evaluation when you're standing and your clothes are on, let me just show you this little skeleton that I drew for John Barnes. Okay, you can see the shoulders are uneven and the pelvis is uneven. Well, the whole key and what fascia is your internal body glove. It's actually a spider web that innervates all blood vessels, nerves, and tissues. So any trauma, any childbirth things, episiotomies, a car accident, low back pain, hip pain, the pelvic floor is so important. It is what joins the upper part and the lower part of your body. So yes, I do treat pelvic floor dysfunction, which is, as everybody knows, incontinence, lack of sexual orgasm, endometriosis, anything that falls in the range that you'd see a gynecologist for a woman or a urologist for as a man. And but fascia is different than regular massage. I am not a massage therapist. I am a nurse. And you don't use any lotion at all. It's just directly on the skin with one hand going one way and one hand going another way. Now, why is that? It's very intuitive. And fascia, when it gets restricted, gets glued down. It has a tensile weight of about 2,000 pounds. Can you imagine that on your organs? I mean, it's amazing. And so it's not one of these therapies that the patient lays down on the table and, oh, I'm going to fix you and I'm just going to get rid of all the fascia. I constantly am talking. It's an educative session. I am always tuning in with a client to see what she feels. And I ask her if she feels any referrals, because if she feels referrals, which means that if I'm on the left side of the hip and she feels a referral down her right leg, yes, fascia crosses the midline, and fascia is only interrupted by transverse planes, cervical, thoracic, and pelvic. So if she feels a referral on her right leg as I'm working on her left hip, well, that tells me that that might be the next place to treat. So people are amazed about what happened in my relation. And they learn how to tune into their body, because to be honest with you, without awareness, you can't figure out what's going on in your body. And so by listening and telling me and feedback to me about referrals, it helps me. Then I developed Pelvicology. So instead of the sensor, to put the sensor in, because I'm not computer literate, obviously, I was nervous about coming on this Zoom call. I treat the vaginal area like a clock. And so I have a little thing to show you. So the client always knows that 12 o'clock is the bladder, that's the anterior side, because that's the front side. And 6 o'clock is the coccyx, that's the posterior side. And so it goes 12, 1, 2, 3 this way, and that's the left side. 3 o'clock, it's right at the left hip. And then down to 6, and then all the way up 7, 8, 9, and that's the right side. Now, my finger, I use a finger when I do vaginal myofascial release, pelvicology. And I use the middle finger. It's not very long. Things have been in the vagina that are bigger than this. So it's usually not painful, to be honest with you. I can reach into 3 and 9, and I can assess whether they have prolapse uterus, prolapse bladder, And I can also assess the vaginal area. Now, I don't know if any of you have ever bitten the inside of your cheek. And have you ever bitten it? And you kind of feel that line, you know, and then you're always touching it and that line. Well, the inside of the vaginal wall should be just as smooth as your cheek. So when you bite your cheek and get that line, that's a fascial restriction. So with vaginal areas, if I go in and I feel a restriction, I've educated them, like I treat it like a clock. I say, I feel, first of all, I assess their coccyx. If their coccyx is flexed, then I put it back. It's just, all I have to do is put my finger on it, and it's very natural, energetic way of just having it go back in place. Because if the coccyx is flexed up like a hammock, it looks like an old hammock, but if it's flexed down, it's holding it taut, the PC muscle. So then I go up the left side of the vagina and I say, well, I feel something here at number 4. And then I ask them what they feel. They give me feedback. As I say, I put my finger on the restriction. Obviously, I use gloves and non-latex gloves. And lots of times I feel where it is referring to. And that tells me what's going on, because fascial restrictions, it makes such a difference because the fascia, the pelvic floor does connect the upper and the lower part of the body. So you could have an unbalanced pelvis, you could have low back pain, you could have burning and fire in your bladder, and incontinence, and obviously constipation, and I treat all. So the confusion about the pelvis is very common and understandable because of the uniqueness of it. So it really joins this internal spider web of fascia. So do you all have any questions, or do you want me to go on?
That was fantastic. And I just want to reiterate too, just with my background in massage therapy, I remember learning about the fascia early on and really understanding that the fascia is the connective, like you said, the glove that holds everything together. It's basically like our little, it's almost like a jumpsuit for our body. And I found it really interesting how trauma, whether that is, like you're saying, whiplash, habitual poor posture, or even things like horseback riding, or any other, as you say, traumas that have been held in the body. The fascia, I think, is really where trauma is held in the body. It's not necessarily in the muscles. Yes. That was my understanding, is that it's held in the fascia. And have you noticed when you've worked with women that there's also been a lot of emotional work that goes hand in hand with this?
Yeah. What you're totally right. Tissue has memory, and when we accept that premise that tissue has memory, because a lot of women that I work with, it's helpful that I have a counseling degree, because if they've been traumatized, sometimes we do some art therapy. This is a picture of a vaginal area, and it's under lock and key. So she feels very safe. So, and I've learned so much, and women need to be empowered. And so tissue has memory. And so sometimes they might have a little abreaction, and that's when they have a realization or a memory pop up. But since I have the skills, so I can titrate that abreaction so it can't get out of control. So, and that actually, I started working with women that had been abused and people that had been raped and everything, and was traumatic for them. So that setting has to be educational, and you have to hear what the women are saying. So when I do myofascial release, I have a patient on a hospital gown. And the reason why I do that is because if I do internal work, they have the hospital gown and it kind of shades, covers the pelvic part. And so all I have to do is look when I go in with my finger, and then I cover them up immediately. So that they feel safe and secure. And that's an important part of the therapy. Because a lot of people say, why do you use a gown? You're doing massage. No, I'm not doing massage. I'm doing myofascial release. So everything is connected. It's like, as John Barnes used to say, it's like the tent poles holding up the body inside internally.
Yeah, absolutely. Absolutely. And how many sessions do you find it takes working with women for them to notice really big results or have it reversed?
I usually have them come back within a week to 10 days because I want to see how they react to the first one. Okay. Sometimes I have a woman on the table that feels no restrictions. They don't feel anything. And then I'm always interested about how they're going to feel a week later. What happened? And myofascial, even though you have the session for an hour, which is what I treat, it lasts and it continues working. It's a very gentle therapy. So sometimes those women come back and surprise me and say, yeah, my vaginal area feels more open. You know, my hip feels a little bit better, where they said nothing on the table in the first visit. So it's very important to have them come back within a week to 10 days. And usually if it's complex, like incontinence, it depends on, well, you have to put in perspective when I started this work. It was in 1985, 1990. When I found out about myofascial, I went and took all of John Barnes' course. I worked with John Barnes in 1990 and helped him develop the, he has an intensive program. And actually I do too, that people come and spend a week, 2 weeks. Now his intensive program, I guess, is 4 weeks. And if massage therapist, you probably get his brochures, Myofascial Release, and they always have these lovely seminars. So I've taken every single one of them. And so because John Barnes did the Pelvicology on me, he finally now has women's health, and he's finally now teaching others how to do it. And that was like in 2000 when he started doing that, which was great. So I worked with him in 1990 and helped develop the intensive program. And then I carried it over to my practice. And so while the rest of the people in behavioral medicine clinic, and we had a continence clinic at Paoli Hospital, were doing the biofeedback, I got the complex patients and I did myofascial release on them. So if you're very complex and you have incontinence, I always have to know. I used to have them make bladder records. I always have to know how often they leak, if they wear a pad. Now, back in the 80s and 90s when we were doing this, diaper companies weren't born, you know, and now they are. And when they were initially born, they had big diapers and everything. And now you have to wear a pad. And so the pad is supposed to keep you clean. It's like not acknowledging that woman's body is magic. You need to wear a pad to keep yourself clean, unless you're having incontinence, obviously. But the incontinence people tried to buy us out several times, but we were never bought because so do you have another question?
It actually just cut. It
oh
just,
dear.
yeah,
Okay.
just cut out at the end. If you could repeat that last piece, because you're saying the incontinence company was trying to buy you out.
Trying to buy us, yeah, trying to buy us and put us on the shelf. So finally, we did sell to a biofeedback company that made obviously the home trainers that we had and the sensor, the peritoniometer, smaller and more computerized. So we did sell that, and we had a home rental business and I still am connected with that. I don't have anything to do with the business, but I still refer to a business in Tennessee that you can rent home trainers. Very often, the whole problem is fascial restrictions, and that's why mainly the people are coming in with pelvic pain. A lot of pain with intercourse, and a lot of hip and neck and back pain, because you cannot treat the bottom of the spinal cord without finishing up a session with cranial. So I might do pelvicology, down at the end of the spinal cord, and then finish it up with cranial. I also do with myofascial. I don't always do pelvicology. About 60% of my practice is pelvicology, and 40% of my practice is somebody has a shoulder injury, and I've saved some people from having rotator cuff surgery. Somebody's had a new hip replacement and they have a lot of scar tissue or a knee replacement, and I help them with that. You know, low back pain is my specialty, hip pain is my specialty. And usually, you know, women, if they're resistive, I treat them straightly with myofascial. And then when I build trust and say, you know, if I could do internally, what happens is that you can get at the internal workings of your hip and also your low back. So
yeah, and that's so important. And
that, yeah.
I'd love to chat a little bit more about that piece, because I feel like even though it's, I'm sure, a little bit more mainstream now than it was when you first started, but it's still such a taboo topic for women to seek help around this area. And what do you find the biggest challenges are for women to either self-identify with the work that you do and or feel like safe enough or have enough courage to go get the work done? Because I see women who suffer with incontinence and pain during sex and stuff, but they are just kind of like, no, I'll just deal with it, or it's just something I have to deal with and I just got used to it. It's like there's a barrier to them getting that support.
Well, if they understand the fact that pregnancy and childbirth can cause a myriad of pelvic floor issues by 18%, and then by 38% if you've had more than, if you've had 3 children. So if you have 1 or 2, you're between 18 and 38% of having pelvic floor dysfunction. Also, it increases as you get older because the estrogen leaves the body. So estrogen rejuvenates the pelvic floor. And so by 50 and 60s, due to loss of muscle mass and estrogen, a lot of women come in and say, oh, I've been leaking urine. But, you know, it's no big deal. It's just when I run. I have a lot of runners, and I have a lot of bikers, and I have a lot of aquarium people that ride horses and everything. So that's no big deal. I just wear a pad. Nowadays, people can wear a pad. Well, that's not normal. You shouldn't have to wear a pad. The problem with incontinence is that it increases with age. And if you don't take care of it initially, then you'll have a problem. Youngest patient that I've ever treated, not for incontinence, obviously, is children. I've treated babies that have reflux and stuff, and a 6-year-old and above. And the oldest one is 94 years old, and she came in for incontinence, and she was wearing a pad, and it took her about 8 sessions because she was 94 years old. But she comes back about once a year and checks and makes sure that her pelvic muscle is doing good. And you know, you gotta love her because nobody ever talked about pelvic muscle. So it was good for her. The other thing is that pelvic, a lot of women, as they get older, they have pain with sex. And that is not openly by doctors. And nobody ever told me about Kegels, by the way, when I had my 3 surgeries, actually 4 with a hysterectomy. I then never said, go home and do the Kegels, you know? And there's a lot of myths about the Kegels, and some of my clients have been bringing in things. The goal is to have a 10-second hold because it builds up the tonic part of the muscle. If you just contract and relax, or you sit on the toilet and stop and start your flow of urine, then all that can do is give you a urinary tract infection. And but in 1989, we got a government grant, and we developed a home trainer to go along with the sensor so people could practice at home. And then in 1992, also NIH gave us a grant. And so by preventing people from having surgery for incontinence. The urologists didn't like us when we'd go to the urology convention, and the gynecologists didn't like us because obviously they see one thing of doing surgery. So OB-GYN physical therapy was started in the 1990s, and I helped with Elizabeth Noble, who is very famous in writing books on childbearing years. start the OB/GYN physical therapy. But physical therapists, if they don't do myofascial, it's not the same thing as what I do. They're very good at evaluating the pelvic floor and everything, but they're also locked in by insurance. And, they can only treat you so long. I like to treat the whole body. The whole body needs to be treated because the fascia system, as we know, head to toe, uninterrupted except for those transverse planes.
Yeah, absolutely. Oh, it's so much good information. Okay, I'm going to check really quick to see if we have any questions so far. And we have Janice on too. Janice, if you have any questions, you can feel free to unmute yourself. Let's see. Okay.
Hi, Janice.
Hi.
Hi.
Hi, Les.
Hi. Do you have a question?
No, I don't actually. It was very thorough.
Oh, good. Well, I do treat other parts of the body. I treat neck, sometimes neck injuries. I have to treat shoulder injuries, hip injuries, and I've also had a run lately on legs. And lots of times that ends up doing with pelvicology, but lots of times with like neck injuries, I don't have to do pelvicology.
Yeah,
So,
I saw Lesley 10 years ago for lower back issues. And now more recently, I have arthritis in my neck, and Lesley has helped me tremendously in both areas. So I'm forever grateful for her expertise and talent.
oh, thank you. Remember that myofascial is not a massage. It's a partnership between myself and the client, because it's important to focus on what's happening in the body and that you want to get feedback from them. And especially, as Nicole said, tissue has memory. This awareness it's a gift for women because they need to be aware of their pelvic floor, coming from one who wasn't very aware in 1985, that's for sure. So let's see what else.
Well, and Lesley, your story alone of having those surgeries and having children and healing is just a testament to this works. And I think there's a piece where I think a lot of women, because they normalize their symptoms, like I have had symptoms of endometriosis my entire life. I haven't been diagnosed with it because I haven't had the surgery or like them to go in and like say this for sure is what you have, but I have the symptoms. And from when I was 12 up until like 25, I was just thought I was one of those people that just had really bad periods. And that's what doctors had told me was you either get a hysterectomy or you go on birth control, even though birth control didn't ever help my symptoms. And so part of me felt hopeless and helpless because doctors were kind of shaming me for not getting a hysterectomy whenever I would go in. And I think there's an element of women, like you were saying, like they've normalized the pain and this is just a part of aging, or this is just what happens after childbirth, or I've always had these horrible periods, so it's just I'm either going to get a hysterectomy or just deal with it. And this is so important for women to hear, that there are alternatives to the surgeries and there are things that natural, gentle ways that can actually help you reverse or minimize the symptoms that they're having.
Yeah, I was so glad that you talked about natural and healthy ways, because endometriosis is just a lot of fascia restrictions. That's why they can label it endometriosis, but it's a lot of fascia restrictions. So with my endometriosis patients, I do visceral work on them. Okay, and visceral work is Paul John Burrell invented it. He was in Canada. I studied with him a little bit, and it involves going around the abdominal area, and especially in the left lower quadrant. There's usually a lot of fascia restrictions, because that's where the large colon kinks and then, obviously goes out the door. So, by doing visceral work, and it's kind of a gentle, a circular massage in the abdominal area. So I include that in And I also do bimanual when I'm dealing with endometriosis, where I have one hand under the back and one hand on the abdominal area, and I'm going and seeing where the fascia is and the restrictions. And when I get to a point where like this, and I'm at a restriction, I hold it. So you have to hold it for sometimes a minute, you know, and then the patient will feel, oh, I feel something. It feels warm. I don't know what to say. You know, and they often can't describe it, but they just say, I just feel a release, you know, and they don't even know what a release is. So
I love that.
I like complex patients and endometriosis, and
well, I'm coming for you.
I'm
coming for you in
painful.
September.
What I had. Yeah. So I'll be glad to see you. Yeah. So, but you know, you have to be able, and I always ask a patient about their sex life. Do they have any pain? Because they didn't have pain. And there is, you know, I don't like to say everybody has a G-spot. They don't all have a G-spot. It's supposed to be the Skene's gland on the anterior wall of the vagina. So I tell women how to find that sensitive spot is just to put their finger in the vagina this way and just say, come like that. I'm not meaning come for an orgasm. It's just like making that signal to come. And that's the sensitive part of the anterior wall of the vaginal area. Yeah. So.
Well, and even that might be a gold mine for someone, because a lot of women don't know how to find that part in themselves. And for men watching, it's also a way for them to do that as well. So yeah.
Yeah, and women don't like to touch themselves down there. And you know, I introduce and help my patients to get comfortable with that, especially if they want to see if they're squeezing right. You know, they can just put their finger in the vagina and see that. I mean, nowadays we have computer programs where one patient came in and showed me her iPhone, and the bouncing ball was going up and down, all these things, and she was doing that with her vagina. Well, it's not going to do any good. You have to build up the tonic part of the muscle. You have to do the Kegels correctly. And Kegels are boring. And so 85 to 100 Kegels a day till it gets secondhand to you, that you just don't even think about it. Like I'm doing a Kegel exercise right now. I can talk. I'm not holding my breath. I'm still holding my PC muscle. And it's just something that comes naturally. And I've never been incontinent since, and I'm 79. So.
That's awesome. I love that. It's also really, I'm sure, a grounding practice that women can use too, because when you're doing a Kegel and holding it, it's a way to be grounded in that part of your body, bring awareness to that part of your body, and build up that strength. Right. So it's really powerful.
Well, they're doing things like tantra yoga nowadays, and they're more aware of the pelvic floor. So, I mean, I think that's all that stuff to increase awareness is really good, and have a woman feel, you know, comfortable with their body. And all bodies are beautiful. Because I was doing sex therapy, we go to it's called a SARS weekend. It's called Sexual Attitude, SAR, Sexual Attitude Readjustment. In other words, we spent the whole weekend looking at how different people do sex and all the different ways and all the different things that people do in sex. Well, once you've spent 3 days watching those videos, somebody can come into you and talk to you about anything and you're not fazed. And that's really what is very, very important. The therapist has to be comfortable in her own body, in her sexuality, to be able to encourage women to be comfortable in their sexuality.
Absolutely. That's so important. Absolutely important. So as of right now, I'm not seeing any questions. Anyone watching live, feel free to pop in any questions. We'll also both be online after to answer any, if there's any replay watchers. I know there's going to be a lot of replay watchers just due to the nature of the time of day we're hosting this.
Yeah. People are working.
Yeah, people are busy. But Lesley, this has been such an honor, and you're such a wealth of information, and this is so important for women to hear. And if people are wanting to work with you or curious about this, where can they find you? How could they get in touch? what are some
Yeah.
options they
At
have?
East-West Integrated Medicine is where I work. And I am sitting actually in the Clear Mind Neurofeedback here, and we have Salt Spa here. I've been with Dr. Nita Desai, who's an MD that runs this East-West Integrated Medicine since 2013. So I've been here 8 years. And they have neurofeedback here. They have lymph enhancement therapy. They have PEMF, pulse electric magnetic therapy. They have laser treatment, alpha brainwaves, Ayurvedic spa, and then me, Pelvicology. That's me. And I always include on the back of my brochure my cell phone, because I don't mind if people call my cell phone. Leave a message, because I don't answer if I don't know you. But if you're a client of mine, I put you in my cell phone. And if you leave a message, I'll call you right back. Absolutely. And my cell phone number is 720-334-2916. And since I live alone with my dog, I don't mind getting phone calls at night. And East-West Medicine phone number is 3444-1999. And I wanted to add one other thing. This is a picture of my pelvic floor evaluation. This is a sheet that I fill out every time I see a client, and I write like number 1 visit, number 2. So they track what I'm doing. And on the pelvic floor right here, it shows the diagram like I showed you, the big with the 12 o'clock and the 6 o'clock. And I write down where the restrictions are. And then, you know, usually by the time I release some restrictions, which I usually do in the first one, they might come in with 5 or 6 restrictions. And the second visit, they might only have 3 or 4. And then when we get down to 2 restrictions, I start them doing Kegel exercises. So everything I do is on this sheet. Or if I do just straight myofascial release, all my techniques are on this sheet, so I can circle and do it. And the other thing is I do charge $120 an hour, and I do give you a super bill. So I give you a diagnosis and of various things that I treat, like abdominal distension, cervical pain, constipation, diarrhea, dizziness, dysuria, endometriosis, fatigue, headache, hip strain, shoulder strain, low back pain, menopause syndrome, pelvic pain, radiculopathy, postmenopause stress, urge, or mixed incontinence. So they always get a super bill, so they can turn it into insurance.
Oh, that's awesome. Awesome. We'll also drop the links for how to get a hold of Lesley. She's based in Boulder, Colorado. And so we'll have all of that information on here as well. And Lesley, thank you so much for being on today. It's been a pleasure.
Well, I really appreciate it. And that was a wonderful hour. I can't believe we almost did an hour. Wow.
Yeah, it went by fast.